Hello, everybody. For the next 30 to 40 minutes, we will be discussing how next generation imaging interacts with precision oncology in the year 2000. Here are my disclosures. So at the outset, we should distinguish between precision health and precision oncology. Both use similar technologies, but in different roles. These technologies are highly specific molecular diagnostics combined with highly sensitive imaging, enabling early cancer interventions, but in two different clinical scenarios. In precision health, the idea is the early detection and appropriate targeted treatment of traits or abnormalities that predict the future likelihood of impairment of human health if undetected. So first come, first saved concept. Precision oncology is something quite different. Here, there's a detailed knowledge of the changing tumor biology that's developed. And the idea here is to give the right treatment to the right patient at the right time for the right duration in order to keep cancer patients as well as possible for as long as possible. So, two different scenarios. When we think about next generation diagnostics, we're not only thinking about imaging, but also other analytes, such as tissue samples, such as tumor markers, such as immunohistochemistry, circulating tumor DNA, etc. Now, of course, imaging is important because it gives you a volume of disease, its distribution, the viability of the disease, its response to treatment, receptor status, and metabolism, etc. And we now know that there are a number of these next generation diagnostics which are poised to affect clinical decision making, either prognostically or by predicting likely response to treatment. So, for example, if you have a test that look at your DNA repair status, then recently some of you will have seen that the FDA approved PARP inhibitors for this indication. And similarly, if you have a mismatch repair defect, then immunotherapy has also been licensed for this indication. Now, imaging provides a measure of tumor activity, and when you use one of these next generation drugs and you monitor across time, you're able to see if there is primary treatment resistance that develops, or whether there's a period of stability or some response before progression emerges. Now, with a more sensitive technique, hopefully you detect disease occurring earlier, and I'll show you evidence for this later on, that enables you then to go on to the next treatment and the next treatment and the next treatment, so you can get multiple treatments in while keeping the burden of disease as low as possible, with the aim, of course, to give the right treatment for the right patient at the right time and for the right duration. So we can think about a happy, healthy cell which then becomes cancerous due to a variable number of cancer-initiating mutations depending on which organ these arise in. Then as the cells compete with each other, subclones then begin to develop. Because of Darwinian evolution, they're just from competition. So by the time they present, so say at this point here, you have a number of different clones. So you've got blue clones, you've got pink clones, you've got green clones, and you've got yellow clones, and they're all mixed together like this. At this point, we tend to give our therapy after discovery. It shrinks some of these clones, it eliminates other clones, but some clones survive. And then you can see the emergence of new clones, and then these compete with each other, and new resistance clones begin to emerge. And this is what causes this phylogenetic tree of evolution, which is very similar to what Darwin described. So a number of mutations occur in a number of hallmarks of cancer, and some of these hallmarks of cancer are visible, such as dissemination of disease, invasion, angiogenesis, proliferation, metabolic reprogramming, etc. So can we see Darwinian evolution occurring in practice? Take a look at this movie and we'll come back and discuss this shortly.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
Having seen this movie, we have to ask if we can see a similar phenomenon occurring in patients, and what technique would you use? Let's imagine the petri dish to be the human body, the bacteria to be the tumor cells, the antibiotics to be anti-cancer therapy, and the light camera to be medical imaging. What medical imaging would you use to see proliferation and clonal evolution? In fact, you have a number of PET and non-PET techniques that might be suitable. So under the non-PET techniques, you have diffusion imaging, which in fact is suitable because it looks at cellular proliferation and cellular density. Specifically, I'm talking about WholeBody MRI. So WholeBody MRI is a method that uses diffusion imaging. It combines a morphological sequence with WholeBody MRI, and it is sensitive to both bone and soft tissue disease, sensitive to cellularity and cellular viability, and we'll discuss that in a second. And the advantages of this technique includes its widespread availability. So you can see that this WholeBody MRI was performed in 2012, so nearly 8 years ago now. It's widely available. It's easy to perform, requires no injections. It's quantitative and enables you to do heterogeneity assessments. So let's just look at one patient over time to give you an idea about a movie that took place in this particular patient over several frames, over several months. So at the beginning, at the outset, 2015 in June, this patient has a small lesion in the left breast. You can see a couple of bone metastases. She gets treated with letrozole, which is the standard of care in 2015, and you can see that her primary tumor responds well to treatment and the bone metastases essentially disappear. And certainly 6 months later, although the primary tumor is left, you can see the bone disease is gone. Now this is worrying because this is discordant. Some disease has gone away, some disease has stayed, and sooner thereafter, so roughly a year after the onset, you can see that in fact the tumor is beginning to get larger. Now, let's just magnify that up for you at this time point, and here it is. So June 2016, we can see the lesion is getting larger. Now, treatment doesn't change. She doesn't accept any new treatment. And what you see on the next occasion, August 2016, lymph nodes in the left axilla begin to increase. Still no change in treatment. April 2017, the primary tumor is getting bigger. The axillary lymph nodes are also getting bigger. But now you begin to see new clones emerging and colonizing the liver and also in the bones, but you notice in the bones it's appearing in a different area. Again, she does not accept any new treatments, does not want chemotherapy, so she carries on the same treatment. So you can see the primary tumor grows, begins to necrose, axilla begins to grow, an increasing volume of metastatic liver disease, and large volumes of tumor in her bones, and then she eventually passes away. So if you think about what we just did, we used a whole body MRI technique that's sensitive to the presence of tumor cells, and we just monitored over time. In this particular instance, we applied one dose of the antibiotic, in this particular instance, letrozole, and you can see how the mutations just grew and grew and grew, and very similar, in fact, to the movie that we saw a few minutes ago. Now, how do we know we're looking at cells per high power field? Well, this was some very good validation work that came out of the Marsden a couple of years ago, where they drilled the bone marrow and looked at the number of cells per high power field correlating with high B value signal intensity, with the ADC values and the fat fraction. And you can see that bone metastases positive for tumor cells had a higher signal intensity, a lower ADC, and a lower fat fraction, as you might imagine. So some nice validation of that work, showing that in the bone marrow, the number of the signal intensity does seem to be correlating with the cellularity of the bone marrow. Previously, we also said that this technology was also very good at looking at cellular viability. Let me show you an example. Here's the same patient that I showed you previously, again in 2012, before and after 4 cycles of docetaxel chemotherapy. What you notice is that the signal intensity does go down with docetaxel. The lymph nodes that we see here in the retroperitoneum disappear, and we would call this a good response to therapy based on the signal intensity alone. These are the volumes that we segmented, and then here are the ADC histograms. So it's obvious to see that the ADC histogram shifts to the right side and flattens out, and this shifting and flattening out is related to a decrease in cellularity of the underlying tissues. Now, if we could color code what was alive, and I'm just going to bring that up. So if you could color code everything before treatment, you'll see that, and color them red, you'll see that before treatment, all the voxels segmented are in the red range. That is to say, they are below the 95th centile value, which in this particular instance was 1060. And if we color voxels above 1500 as being dead, so alive, dying, or dead, or no treatment effect, likely response, and highly likely to be responding, depending on the ADC cutoff, we can then begin to map where the red areas are. So you can see these red areas that represent residual active disease, this peak over here, are in fact localized to the right ischium, for example, to the left femur, and to the lower lumbar spine. So we can say with confidence that although the majority of the disease has responded well to treatment, there's still active, heterogeneously distributed tumor within the skeleton. And as I said, this is in the right femur, in the lower lumbar spine, sacrum and the right ischium, as well as being scattered elsewhere within the skeleton. So we would expect that we will be able to find disease or actionable mutations in those areas. So here is an example of finding actionable mutations. So here is a patient who has castration-resistant prostate cancer, and what you see is the high signal intensity in the left iliac bone. This has a low ADC. This was drilled, and here we found a BRCA mutation. So this patient was treated with olaparib. Olaparib is the drug that we talked about previously that has now been licensed by the FDA for BRCA mutations. And you can see that on the signal intensity decreases, the ADC increases, and this is what we were talking about previously. This represents a response. But look what happens later. Later, on the opposite side, you get an increase in the signal intensity and a low ADC. And when this area was drilled, the BRCA mutation had reversed. So it's quite a nice example of using next generation imaging to target a biopsy, to find the appropriate mutation, to treat the mutation, show that it responds, and then show where the relapse is occurring, and then target that area to gene sequence again. So a nice example of the use of WholeBody MRI for precision oncology. So if you map this person, what we said was this is the point at which there was polyclonal disease. You can see a mixed response to treatment, but look what happens at the end of treatment. In fact, the patient hasn't had that much of a response towards the end of a treatment. So if I just put that up, you'll see that this is the prior treatment, this is after 4 cycles, and after 10 cycles of docetaxel. You can see how, after 4 cycles of docetaxel, we were already able to predict that this patient was not going to do very well. And indeed, you can see here in the lumbar spine that giving another 6 cycles of docetaxel has made not a bit of difference to this particular patient. And we know that we have to stop chemotherapy at some stage, and we did after 10 cycles, and we expect the patient to relapse, and lo and behold, you can see that the patient relapses. So the next treatment is often carbazitaxel, and you can see carbazitaxel was given, but again without much of a response, some yellow colors but not many green colors, and after 6 cycles of carbazitaxel, you can see the patient is already beginning to relapse with retroperitoneal lymph nodes beginning to re-emerge. It's only at this stage that the clinicians change to an androgen receptor targeting agent, and you can see again that there is a response with the blockade of the androgen receptor pathway, but again, not a fantastic response. And eventually, of course, the patient passes away. So you can see how we have followed this patient over time, been able to monitor treatment response, been able to predict what was going to happen in the longer term. And although we didn't act on this at this time, we can see that there is an opportunity to act at an earlier time point if we heed the knowledge that we are getting from whole body MRI scanning. And of course, now this software is available for commercial use. So let's just talk about some applications of next generation imaging in various clinical scenarios. And let's start off by talking about improving staging for therapy planning. Now, let's take a patient with a raised PSA. So PSA is raised at 3.3. This patient's from America, so a PSA greater than 3 is considered raised in America. You can see that a whole body, PIRATES compliant prostate MRI performed at 3 Tesla was performed. We can see a PIRATES 5 lesion in the left peripheral zone. This was biopsied, and this was found to be a Gleason 9 cancer. Now, let's just think about what just happened here. This was high precision disease detection using multiparametric MRI with the PIRATES system. This was targeted biopsy, and this was using high spatial information to get high precision in local staging. So all examples of using high next generation imaging to advance diagnosis and staging and characterization in this particular instance. Now, what should be the next treatment for this person? Well, that really does depend on the status of the metastatic disease. This data was published about 18 months ago, 2 years ago, showing that if you have a low burden of metastatic disease, such as here, you get a benefit if you give pelvic radiotherapy, but if you have a high burden of metastatic disease, you do not get a benefit from giving pelvic radiotherapy. How is the burden of disease decided? Well, in this particular paper, it was decided on bone scans and CT scans, which is interesting. So this patient, despite having despite using next generation imaging for diagnosis, returns to an old generation technology, bone scans and CT scans, for his systemic staging. And what you see are two lesions, the left athrib, the right acetabulum, with a normal appearing CT. So this was called oligometastatic disease unconfirmed because there was no CT abnormality, which is why he came for a PSMA PET CT and a whole body MRI. And what you see is the PSMA PET CT is positive in the right acetabular roof, positive on the high B value image, low signal intensity on the fat fraction, but a normal CT scan. Similarly, if you look at the left rib, you can see again positive on the PSMA, positive on the whole body MRI, but negative on the CT scan. And we know that PSMA PET CT, for example, is having an impact in this situation. So this paper was published in the Lancet recently, showing that the accuracy of PSMA is much better than bone scans and CT scans for staging high-risk prostate cancer. You can see the accuracy of PSMA PET CT is 92% compared to 65% for bone scans and CT scans. We are now left with the conundrum as to whether he has low metastatic disease burden or high metastatic disease burden. Defined by the bone scan and the CT scan, he has a low metastatic disease burden, and he would benefit from pelvic radiotherapy because he would get an improved overall survival. On the other hand, if we really thought he had high metastatic disease burden, he would not benefit from pelvic radiotherapy, and that might be a wasted treatment. But what would happen if we treated him anyway? Well, this is where we need to talk about the Will-Rogers effect. The Will-Rogers effect is a stage migration phenomenon. So if you have conventional imaging, you can see that microscopic metastatic disease is classified as being M0, whereas macroscopic metastatic disease is classified as being M1. So if we were to use any particular therapy, let's say radiotherapy, then we would find that the people with M0 disease defined by conventional imaging would survive better than those patients with M plus disease. Now, if you used a next generation imaging technology, such as PSMA PET, the microscopic metastases are now reclassified as being M plus. So in other words, the prevalence of M plus disease increases, the prevalence of M0 disease decreases. Now, if you treated the patients in the same way, this is what would have happened to survival. In fact, because you have diluted the M0 by getting rid of microscopic metastatic disease, they actually survive better. So here's conventional imaging and the survival after next generation imaging. They survive even better. Now, in this group, which is the increased prevalence of M1 disease, because you have now diluted the heavily M plus disease with the microscopic M plus disease, in fact, as a pool, there is a greater proportion of good prognosis patients within the M plus group with next generation imaging. So, in fact, they would survive better. So overall, everybody wins. So there's no reason to curtail the use of the therapy because next generation imaging merely improves results rather than making things worse. Okay, the next thing I'd like to talk to you about is using next generation imaging for the assessment of bone marrow disease. How potentially bad conventional imaging can be to assess the effects of next generation drugs. Here, for example, is a man with castration-resistant prostate cancer who's being treated with cabozantinib, which is a dual inhibitor of VEGF and c-Met. If you look at this very carefully, what you'll notice is the bone scan normalizes fairly rapidly after 12 weeks of treatment, and after 24 weeks of treatment, the bone scan is completely normal. The patient feels better. You can see can't get out of bed, feels like a new man, and then decides to take a holiday. But if you look at the PSA, you can see the PSA goes down a little bit, but then begins to increase. So who do you believe, or what do you believe? Do you believe the patient? The patient feels better. Do you believe the bone scans because the bone scans look good? Or do you believe the PSA? And a lot of people don't believe PSA because we know it doesn't give you a good readout in metastatic prostate cancer. So we did a whole body MRI scans at the 3 time points. And what we see at the 3 time points is that in fact after 12 weeks of treatment, there is a decrease in the signal intensity indicating some response to treatment. But you can see by week 25, the patient is definitely relapsing, although the bone scan is still negative and the patient is feeling well and wants to go on a holiday. And you see the same thing with the color maps that we talked about before. A lot more red color after 24 weeks of treatment compared to 13 weeks of treatment, for example. Now, this drug failed in the clinic. 2 phase 3 trials failed, and there was a bloodbath as far as this is concerned. The reason this 2 phase 3 trials failed is because they relied on bone scans and CT scans to give readouts to a novel drug, and that misled the company and led to financial losses. So you have to be careful about using an old generation technology to trial out a next generation medication. You have to be very careful. We've been using whole body MRI scanning for the assessment of metastatic bone disease for some time. And here's a prospective study that we performed in 43 women who were evaluated every 12 weeks independently by a CT scan, a whole body MRI scan, clinic visits, and blood tests. And the trial was stopped per patient when there was progression that required a treatment change of systemic anti-cancer therapy. What we noticed was that 2/3 of the people who progressed on the MRI scan alone. 1/3 of patients who progressed on the CT scan alone, but we did not have one patient who progressed on a CT scan alone. So MRI was always showing progression. Interestingly, and what might be quite clear to you now, is that 50% of people who were progressing on a bone scan or a whole body MRI scan showed no evidence of progression on the bone scan. And here's an example of one of the participants. You can see here that on the whole body MRI scan, just looking at the bony pelvis, for example, there's an increasing burden of disease. And here is the burden of disease increasing on the high B-value image. Now, if you look at the same level on the CT scans, you see some increase in mineralization. But an increase in mineralization is not a good readout for disease progression when patients are on bisphosphonates, and all patients with metastatic breast cancer are on some sort of bisphosphonate or anti-osteoclastic medication. Now, the bone scan prospective was read as disease extent unchanged, no increase or decrease in volume of lesions, although we can say that there is some increase in the skull vault metastases compared to the pre-treatment scans. But this is how it was read, and this was a prospective study. The last area that I'd like to talk to you about is the use of next generation imaging in theragnostics. Now, a theragnostic that is now quite advanced in its development is using either lutetium or actinium PSMA radioligand therapy for patients with metastatic prostate cancer who are PSMA ligand positive. And here's an example of a patient who has got a PSMA that's positive. The patient was given lutetium therapy. You can see the volume of disease decreases, and that's associated with a decrease in PSA. Now, people who have a decrease in volume, in fact have a much better survival than people who don't decrease in volume. And this is exactly what you expect. And here, this is overall survival. The interesting thing that I want you to concentrate on is these patients here. Why do these patients who have PSMA positive disease not respond to a PSMA directed therapy? The clue comes from this patient. So this is a patient I saw not that long ago, where you can see that there are areas of vividity that are negative on PSMA. So here, for example, is a metastatic lymph node clearly positive on a PSMA scan, but negative on a PSMA. Similarly, this metastatic deposit in the left side of the sacrum is negative on a PSMA, but positive on the FDG PET scans. Clearly, if you use a PSMA directed therapy, it's going to affect this area, but not this area, and therefore it leaves disease untreated. And this is one of the contributors for poor response with PSMA ligand therapy. So it is possible, in fact, to use PSMA and FDG to define phenotypes that may be suitable for anti-PSMA directed radioligand therapy. So for example, if you have a patient like this on the left, where you've got very low uptake on the PSMA, but high avidity on the FDG, this patient would be unsuitable for an anti-PSMA directed therapy. If you had a patient like this, number 3, where there's concordant abnormality between the FDG PET and the PSMA PET, then that patient would be suitable. Similarly, if you had somebody who was positive with PSMA and negative with an FDG PET, again, they would be suitable for a PSMA radioligand therapy. And in fact, you can show that there are survival differences depending on whether you have a concordant versus a discordant abnormality or discordant findings, and the difference in time interval can be 10, 11 months, as you can see in these two plots. As a result of this, this selection of patients has now been tried against a standard of care therapy, which is cabazitaxel in metastatic castration-resistant prostate cancer. And if you choose your patients well, you can get a greater degree of PSA reduction and fewer side effects. And this data supports the using of a PSMA radio ligand therapy compared to cabazitaxel, and of course phase 3 trials are now ongoing. So we can think of a number of challenges for the introduction of these technologies into precision oncology. First of all, we need to integrate multiple spatially heterogeneous biomarkers in 4D space. We see heterogeneity that at the patient level, at a region level, at a lesion level. And this is going to be problematic and probably has a role, and there is probably a role for deep learning and artificial intelligence here. We also need to be able to understand the biology behind the image. What are the molecular mechanisms that result in what we see, and what are the likely therapeutic implications? And this is the field of radionomics. We need to develop roadmaps for the next generation of quantitative imaging biomarkers that are fit for drug development and for precision oncology. How do we do this? How do we develop roadmaps? And we also need to think about how next generation imaging will impact on stage migration, which we talked about earlier, and of course something called lead and length time bias. So I'd just like to spend a few minutes talking about lead and length time bias with next generation imaging in the context of prostate cancer diagnosis. So lead time bias is overestimation of a survival duration due to an earlier detection of deadly disease by a next generation imaging technology compared to conventional imaging. So let's say you have one patient who's diagnosed conventionally. If the treatment doesn't work, the patient will die at a particular time point. If the same patient was detected earlier by a next generation imaging technology and the treatment doesn't work, so in other words, you don't postpone death, then paradoxically, the lead time bias means that the patient would be perceived as having lived longer, when in fact the patient really hasn't lived longer. Length time bias is something quite different. Length time bias is an overestimation of survival duration because next generation imaging technologies are more likely to detect indolent diseases that progress more slowly, because there's a greater opportunity to detect more indolent cancers, and because they live longer, there's a bias towards a lengthening of survival times because we've just got more indolent disease. Now, do we see this in the setting of multiparametric MRI with prostate cancer? Now, a number of studies have now looked at this and have shown that compared to the systematic pathway, if you only biopsied PIRADS 3 to 5 lesions, then about 30% of men can avoid a biopsy. And this is the main benefit of multiparametric MRI, as most of you will be aware. Now, we also know that if you undertake this strategy where only positive scans have a biopsy, you lower the detection of clinically insignificant cancers. In other words, you would have the effect of eliminating length time bias because you are detecting fewer indolent cancers. So that's a positive. Now, what about the detection of clinically significant cancers? It turns out that if you look at the detection of clinically significant cancers, whether you define it as ISUP2 or ISUP3, there is no difference in the MRI pathway where you only biopsy the positive scans versus the systematic biopsy. So that would mean that there's going to be almost no effect on lead time bias due to using a next generation imaging technology. However, we still need to worry about grade migration because targeted biopsies, which is what we were proposing to do in PIRADS 3 to 5 lesions, is more likely to occur because MRI sees a an ISUP3 lesion more than it sees an ISUP2 lesion, more than it sees an ISUP1 lesion. So let me just show you that. So let's take this prostate. Here we are, a large prostate gland with a big prostate cancer. At prostatectomy, this turns out to be a 3+4. So in other words, ISUP2. The MRI is very good at showing the highest density area. This highest density area is likely to harbor higher Gleason score. So 4 plus 3 if you targeted a biopsy just through that area, and that would lead to an overgrading of, of the tumor. On the other hand, if you were to put two systematic cores randomly using a systematic biopsy, you're more likely to hit Gleason 3 plus 4s, but also 3 plus 3s. Less likely to hit that core. And overall, the systematic biopsy may actually give you a better idea of what's going on than an MRI targeted biopsy. In other words, this would be the Will Rogers effect. Now, does that occur in practice? Well, it doesn't seem to. It doesn't seem to. So if you look at this paper that's just been published examining that issue, what you find is that the MRI biopsy is less likely to be upgraded to compared to a systematic biopsy, compared to the prostatectomy specimen. So it may be that we're worrying too much. But it is theoretically possible, and we do need to develop new prognostic models based on MRI biopsy, which need to be developed and then validated nevertheless. Now, this looks great. We can expect everybody to take up next generation imaging technologies, and yet we find we don't. Why does that occur? Well, generally there's a resistance to changing the current staging and treatment paradigms. Even if we know that the current paradigms and the ways of doing stuff is not good enough. In other words, we keep the faith, remembering that therapy approvals are often linked to the method of assessment, and therefore you get this issue, and that's a problem. We also need to remember that clinicians don't know what to do with next generation imaging technologies and how they should affect treatment. And this often leads to the off-label use of not only of diagnostics but also of treatments. And of course there are lead and length time biases that everybody talks about, but also there are economic forces. Next generation imaging is considered expensive, good for teaching centers, nice to have, and you often find people saying, let's wait for the guidelines to change and then we'll change. And these are real physician and health system barriers to the adoption of next generation imaging technologies. So let's just conclude there. Next generation imaging technologies in precision oncology requires validated imaging, tissue, and blood biomarkers. There's no doubt about that, and they are coming. The roles include more accurate detection, localization, characterization, etc. Imaging biomarkers are already beginning to impact on the biological understanding of tumors, and we can see drug developments occurring because of these with precision oncology implications. So you can already see the use of immunotherapies, of PARP inhibitors, etc. But there are multiple challenges that remain, and these include developing imaging biomarkers, validating them, and adopting them so that they can begin to provide clinical benefits. Thank you very much for listening. I hope this has been informative. Leave me some questions below. Goodbye.